begin. Um, so as you all know, the topic for today will be understanding the how to recognize signs in schizophrenia, especially using that to refer patients when these are detected early, because there are implications associated with early detection and treatment, as we all know. Okay, let me put this up there. Okay, so I'm just going to begin with a broad overview of psychosis. What psychosis is, as schizophrenia is a type of psychosis. So generally, we've been hearing psychosis all the time, especially with those in the mental health field. We tend to hear it a lot, and we have different understandings of it. But when it comes to literature, there are certain criteria that have to be met when it comes to psychosis and for that matter, schizophrenia. So in general, when we what we understand by psychosis is when you lose touch with reality. So in simple terms, when someone loses touch with reality or contact with reality, that is psychosis. The word originated from the Greek two phrases called psych and then osis. So the psych means mind, and the osis means an abnormal condition. And the history, well, when we get to the history of schizophrenia, I'll talk a bit about the psych and then the osis as well. So, like I mentioned, the schizophrenia is a type of psychosis. So, generally, when people think of psychosis, the first thing that comes to mind is schizophrenia. There are others who actually believe that schizophrenia is maybe just psychosis or synonymous to psychosis, but there are different types or classifications of psychosis. And this list is not exhaustive. There are other types, and also depending on the classification systems, as we tend to have different classification systems for mental illnesses. So, we have acute and transient psychotic episodes. These are usually of short durations, usually about 3 months after the onset of symptoms. They tend to resolve 3 to 6 months. They tend to resolve. Schizophrenia, as we all know, is a chronic form of psychosis. We have the schizoaffective disorder, where we have schizophrenia together with an affective disorder, which could be depression or mania. So the delusional disorders are also usually sort of chronic, which are difficult to treat, as we all know. And they are usually mostly monothematic, so just limited to one type of delusion. I'll be defining some terms later. I'll be explaining what delusions and hallucinations are to get a better understanding of it. We also have psychotic disorder not otherwise specified. These are usually when it doesn't fall into any of the criterias. So psychosis can occur in other disorders as well. So in depression, when it's severe, it could occur in it. People with bipolar could have people having mania with psychosis. People who use substances, illicit substances or psychoactive substances can have psychosis as well. So that's where we have substance-induced psychosis. So cannabis use, cocaine, amphetamines, most of these psychoactive substances can induce psychosis. We could also have psychosis in dementia and delirium in PTSD. And also, we have what we call shared psychotic disorder. So this is where we have the folia a folia atria, where someone can have psychosis and another person who is close to the person can sort of pick up these symptoms or share these symptoms with them. So now on to our main topic, which is schizophrenia. Um, Schizophrenia, what comes to mind? Someone saying something? Okay. So schizophrenia times usually is a brain disorder, and this tends to affect how people think, how we feel, and how we perceive things. So the hallmark of these symptoms are usually psychosis, and psychosis can be experienced as delusions or hallucinations or abnormalities in behaviors or speech. But generally, when it comes to schizophrenia, the most common type of um, symptoms experienced regarding the psychotic symptoms is the auditory hallucinations. Even as much as 75% of them tend to have auditory hallucinations. The history of schizophrenia dates back the 1850s when they tried to define it. So Morel, who is a French psychiatrist, had a name for it, dementia precoce. So that's the name he came up with. So along the line, there are different names for it. Different psychiatrists coming up with different names and definitions for them. Previously, it was called uh, Eugene Bleuler, who is also one of the prominent psychiatrists, called it manic depressive disorder. But then the term schizophrenia itself was coined by Eugene Bleuler, who is also one of the prominent psychiatrists. In terms of epidemiology, um, the age of onset is usually between the late teens and then mid 30s. In males, generally in the early 20s that's where it peaks. So around 25, that's the average age of peak. For females, it's usually the late 20s and early 40s. So they usually have two peak ages. Then the male-female ratio is almost the same. In the general population and even worldwide, the prevalence is about 1%. I looked at some papers in Ghana, and most of them were between 0.17 to zero point 0.2. But research in Ghana is still developing, especially in the mental health area. So this age is important in that you don't just go about having schizophrenia as your first impression, or when people come in certain age groups to you presenting with psychotic symptoms. So if someone comes is 50 years and for the first time is presenting with psychotic symptoms, that wouldn't be the first thing to come to your mind. So that's how important this age group is. So there are different etiological theories for schizophrenia, and I know you are quite familiar with those. The neurotransmitters, dopamine, serotonin, glutamate, GABA, and adrenaline. You have the neurodevelopmental hypothesis where due to certain birth traumas, could predispose people to schizophrenia. Then we have the genetic bit where mutations in certain genes, the DIX1, neuroglobulin, the dopamine genes, the COMT could also predispose people. Then drug use, especially in teenagers, predisposes people, increases the risks. The becomes higher compared to people who don't use drugs. So it tends to precipitate schizophrenia in people who are predisposed to it. So this is just something to let us know that it's not every time that when you have these symptoms that it could be something that is chronic, because in certain conditions you could present with some psychotic symptoms, especially hallucinations, and it could just be something that is temporary and would resolve within a short time. So I'm sure most of us have experienced these things. For instance, sometimes when you are drifting into sleep, you may hear someone mention your name or someone say something, only for you to open your eyes And then actually no one may be around, or even if someone is around, you ask the person whether they called you and they'll tell you they didn't call you. Or maybe when you're waking up from sleep, then you hear someone mention your name and but no one actually mentioned your name or said anything to you. These are called the hypnagogic and then hypnopompic hallucinations, where people tend to hear voices due to impaired level of consciousness. That's when they are going to sleep or waking up from sleep. So people who are also bereaved, who have lost loved ones, uh, and those who in extreme states of distress also can tend to experience hallucinations, and it's common for them to hear the voices of their loved ones. Sleep deprivation, when it's severe, could result in that sensory deprivation, and even caffeine intoxication, though rare, has been shown to cause some hallucinations or some delusions. Now, to define a few terms in schizophrenia, we commonly encounter hallucinations and delusions. So, what are hallucinations? These are perceptual disturbances occurring in the absence of external stimuli and can be experienced in various modalities. So, generally, we experience them in the various senses. So, could be auditory, it could be visual, could be gustatory, that's the taste, olfaction, which is smell, and then tactile, which is touch. So, like I mentioned earlier, the most common type is the auditory hallucinations, where you can even find it in up to 75% of people with schizophrenia. So it's not enough for someone to just tell you they are hearing voices and then you say they are having auditory hallucinations. We have what we call mental imagery, where we all, and this is something we all experience. These are internal thoughts. So that thoughts in your head that sometimes you tend to deliberate with yourself to advise yourself and have discussions with yourself. These are mental imagery. So it could be voices or even pictures or videos that you play in your head, but these are usually not vivid compared, especially the images are not very vivid compared to, let's say, if it's a visual hallucinations, these images are usually very vivid and well defined. They're able to define the character, what they are wearing, and then where they are standing and all that. But when it comes to mental imagery, the visual aspect is quite vague. With the auditory hallucinations, they tend to hear these voices from external space, so from outside their ears, as if someone is talking to them. This is different from the voice you hear in your head. This is usually you know that is in your head, but sometimes it's quite difficult for certain patients to or people to differentiate between these two. But generally, the typical characteristic of this voice is that it comes from outside. They know that it comes from outside. And these voices are usually difficult to terminate at will. So that's why it can be quite distressing to them because they can't voluntarily stop their voices from talking to them. So these are some of the qualities of the auditory hallucinations. So it's not enough to just for someone to just say they are hearing voices, and then you say that they're having hallucinations. Also, it should be heard in clear consciousness. If someone is sleeping or has some impaired level of impaired consciousness, then you wouldn't say they are having true hallucinations or hallucinations as we put it. So we have pseudo hallucinations, but with true hallucinations, the level of consciousness of the person should be clear. So yeah, that is just a summary of hallucinations. So with the auditory type, it could come in first person, I mean, second person or third person auditory hallucinations. So it just is about English grammar. So second person, you. So they communicate to you in that manner. You are a fool. So usually it could be derogatory or just depending on the individual, it varies. So you are doing this, you are doing that. Don't So it addresses the person in the second person. So with the third person auditory hallucinations, they tend to address the person in the third person. So what they do is to usually discuss, so they can be discussing this usually mostly in several voices. So they can be discussing the person. So he did this, he did that, he's doing this, he's doing that. So they could be discussing the person or running commentary or on what the person is doing. And these are quite significant and are termed first rank symptoms. That's the third person auditory hallucinations. Um, with the tactile one, it could come in various forms. Could be within the body or on the body. So you could find it on skin where people complain of insects on their skin or termites or infestations, or maybe they feel their intestines or the internal organs twisting and all that. So these are all types of tactile hallucinations. With the olfactory ones, they will complain of certain smells, but then other people are unable to smell these things. And they tend to have these abnormal taste when nothing is actually ongoing. So that's it for a brief summary of hallucinations. With delusions, this is a term too that we tend to commonly use. Could actually use it in a derogatory manner to tell people that they are delusional when you don't believe what they are saying. So it's defined as a false, fixed belief that is firmly held despite clear evidence to the contrary, and it is not consistent with the person's culture. So these delusions come in various forms. Okay. There are different types of it. So I've just named a few, which these are usually common in schizophrenia. And one most common one is paranoid delusions. Generally, when someone is paranoid or has paranoid delusions, people conclude that they have schizophrenia, but that's not the case. The other the other types of psychosis that could present with paranoid schizophrenia. So, paranoid delusions could present in two different ways. So, we have the persecutory and then the delusions of reference. With the persecutory delusions, they believe they are being persecuted, or maybe there's some conspiracy against them, or people are trying to harm them, or there are some threats uh, that yeah, people are threatening them. With the delusions of reference, what happens here is that people tend to see themselves as the point of reference around whatever is going. So people are talking about them, people are monitoring them, people are looking at them. The television is talking about them, the radio is talking about them. The song that is being sung on the radio is about them, though they are just making references. So the thing about delusions is that even in the presence of clear evidence, the person will still insist. So sometimes it can be totally implausible, which are the bizarre delusions, which um, can be so implausible. Imagine you claiming that you are abducted by aliens. So that is totally, aliens do not exist, do they? Unless maybe they exist. But other times too, it can be quite difficult to tell whether it's a delusion, especially if you don't really know the person. So it's when you know the person's circumstances, it's easier to tell whether it's a delusion or not. For instance, if you are meeting me for the first time and I tell you that I'm a pharmacist, you'll not be able to tell whether I'm lying or I'm not lying. So I may actually even have read a few stuff about pharmacy and then, or maybe don't actually know anything about it, but I'll just insist that, I'll just insist that I'm a pharmacist. But because you don't know me, you may be tempted to believe it. You may be tempted to believe that I'm a pharmacist, but if you know me and then you challenge me that, nah, I've never even actually been to pharmacy school and I still insist that I'm a pharmacist, then I'm being delusional about it. So with delusions, they never budge, no matter the amount of evidence you provide or how much you challenge them, they never budge. They will continue to insist on whatever they are saying. So that's how delusions is. They are unshakable. Whatever you do, the person wouldn't move away from their stance. So that is a delusion. With grandiose delusions, that's where they have this um, beliefs about having these supernatural powers or have this self-importance. So it could come in different forms where they believe in their ability. So that's the grandiose delusion of ability. So I can levitate things, I can look at stuff and they levitate. I can heal people, which is common in our settings where people are quite religiously inclined. So they become grandiose and then I believe that um, they have powers to heal people. They go to on the street and begin to pray for people and all that. Actually, um, don't be surprised if some of the pastors that we see around actually have some grandiose delusions. We have also have grandiose delusion of I mentioned the first one, which is what grandiose delusion of what ability. So the grandiose delusion of identity, where they believe that they are important people. So if I believe that I am a member of parliament or I'm the president of Ghana, that is definitely not true. We all know the president of Ghana is John Mahama, but if I tell you that I'm the president of Ghana, then and I still insist on it, then I'm being delusional, isn't it? Then I go on to tell you that I have millions in my account or billions in my account, billions of dollars or pounds in my account. But then everyone knows that I don't have that money in my account. That has been delusional. So these are forms of grandiose delusions. With nihilistic delusions, that usually has a negative connotation. So they tend to believe that they may not have, they don't have certain organs. Maybe their organs, imagine you say you don't have a stomach, yet you eat, you're able to eat. You don't have a heart, yet you are breathing. You don't have certain parts of your bodies do not exist. Meanwhile, everyone can see them there. Or you believe that because of you, some catastrophe is about to occur. So they usually have these negative beliefs. That is what the nihilistic delusions is all about. And these are the common types of delusions that could be found in schizophrenia. So the most important thing to know is that these people tend to have these unshakable beliefs, though people around, everyone around knows that that is not the truth. So it's good and it helps when you know the baseline of the person, when you have some information about the person, if not from the patient itself, but maybe collateral history from their friends or relatives. So if you personally know the person, then it's easier to actually even tell when these people are being delusional. Now let's look at a few symptoms of schizophrenia. So the symptoms in schizophrenia are typically grouped into three, which are the positive, negative, and cognitive symptoms. So the positive symptoms are things that you easily see, you can easily identify. These were things that were not previously present in the individual, but because of the illness, then they begin to show up. So we have the hallucinations, the delusions, disorganized speech. So our speech is a manifestation of our thoughts. So if they are thought disordered or if they have disorganized thinking, that's where it shows up as a disorganized speech. So their speech could be generally um, a speech should be what normal speech should be linear and goal directed. So when your speech, if you are going to D, so you start from A, go to B, C, and D. But then, so that's how linear is supposed to be A, B, C, D. But then you find that what happens is that they can start from A, go to W, go to uh, E, go to S, and then now come back to D. That is circumstantiality. Quite common in the Ghanaian culture, isn't it? You can wind round and round and round and round. Oh, what did you eat this morning? Oh, this morning when I woke up, I went to get my bath, then wore my clothing, took some trotro, and I got to the watch seller. The queue was very long, and I got some watch, and that's what I ate. So the person didn't go straight to the point. The person went to, it would have been easier to just say, I ate watch, but then they had to tell you about waking up and all that. So this is what we call circumstantiality. They start go round and round and round, but then eventually end up telling you what is going on. We have what we call tangentiality, so going off the tangent. So you ask the person a question, what did you eat this morning? Then they just digress. So what did you eat this morning? I had my haircut last week. But the haircut, I decided to go for a down cut because I struggle to comb it when my hair is too much. The person has totally digressed from the question you asked. You are asking about food and they are talking about their haircut. Though whatever they are saying subsequently is still about the hair, but it still doesn't relate to what is being said. So this is tangentiality. We also have derailment where they initially seem to answer the question. So they start off on the right track, but then they digress. So that is derailment. So the derailment and tangentiality are called loosening of association or looseness of association. And this losing of association, when it's severe enough, sometimes the patients can just mutter different words together such that you have no idea what they are talking about. It doesn't make sense. So this is called word salad, and this speech is usually incoherent. So with the incoherent speech, you don't understand what they are talking about. So the speech too can be irrelevant. That's where, though it makes sense, it doesn't relate to what you are talking about. Sometimes these people with schizophrenia also have what we call neologisms, where they tend to form new words. So they can use one word to mean something else, or they just form and entirely put different words together to form a new word altogether. And other times too, what they do is to use parts of something to represent the whole thing. So that is what we call metonymy. So these are some of the types of disorders in their thoughts that they have that will reflect in the speech. With disorganized behavior, what you usually see is it's quite obvious. So these are usually grossly disorganized behavior. And if we tend to hear catatonia a lot. So catatonia is a type of behavior, but then it's an abnormal behavior. So you find that these people may have what we call grimacing, this abnormal facial staring, or they may be staring blankly into the air. They can just stand at one place for a long time, staring for nothing, like staring into the sky, doing nothing. They could have what we call mannerism, where they repeat words, repeat certain actions. These are usually purposeful actions, or stereotypy, where there's this repetition of actions which are usually non-purposeful. So imagine someone just standing there and saluting as if they're a soldier. Meanwhile, there's nothing going on, just saluting or throwing their hands about. So these are usually repetitive movements that they do. And it could be purposeful as if they're actually doing something purposeful, or sometimes it doesn't just make sense at all. They could also mimic what you are saying. So you say something, then they mimic it. So, what is your name? Then they'll also repeat, what is your name? So they just repeat whatever you are saying. Or maybe you try to do something and then they also repeat or copy your actions or your movements. So repetition of your um, words is called the echolalia, and then repetition of your actions is called echopraxia. So you find them repeating your actions or your words. Sometimes they just even repeat random words out of the blue. You find them, they just say down, ka, or repeat the last syllables of certain words. So these are all abnormal forms of behavior. You can find them in abnormal postures. So imagine you standing with your shoulders shrugged. That's quite uncomfortable. And especially to be able to do this for several minutes or hours, that is abnormal. And this is called posturing, or put their hands in certain abnormal positions that usually should be uncomfortable, but then they're able to do that for prolonged periods. We could also have what we call waxy flexibility and some other symptoms where you're able to manipulate or put their hands in abnormal positions. Um, Sometimes they just resist whatever you are trying to do. So you ask them to do something, they resist. So ask them to shake your hand, they resist. Ask them to eat whatever you want them to do, they wouldn't do. This is what we call negativism. And these are just a few of the catatonic symptoms. Other symptoms that you may experience or that are quite obvious are, and I've seen a lot, people taking their baths several times in the day. So every 5 minutes or 10 minutes, you find the person going into the shower to take their bath. This is also um, a disorganized form of behavior. With the negative symptoms, these are usually things that are present in the individual, but then due to the schizophrenia, it's taken away from them.
Hello, Jude.
Yeah.
Yeah, not to cut you, but we are raising against time. So just to nudge you a little bit.
Okay. All right. I'll move faster. So with
Okay.
the negative symptoms, they can lose interest in activities that they previously enjoyed. They lose motivation. That's the evolution. They become socially withdrawn. And you find that these people have these flat expression on their or blunt expression on their faces where they don't show any expressions at all. These their expressions are, I mean, faces are expressionless. And in terms of ad- they are talking, they have what we call poverty of speech. The content of their speech is not rich. They struggle a lot to bring out words and all that. Um, with the cognitive symptoms, they tend to have difficulties with attention and their memory, and how to organize their thoughts. So they have difficulty actually thinking abstractly. They have what we call concrete thinking. So if you give them a proverb, they'll give you the literal meaning of the proverb. They wouldn't be able to give you the abstract meaning of it. And people with schizophrenia tend to have no insight, as in they don't understand that they have a mental illness. Some of them don't actually even know the symptoms that are going on with them. Um, Sometimes there are some people who present with what we call prodromal symptoms. So these are symptoms that usually are quite subtle and may not be noticed, and it can occur 1 to 2 years prior to the emergence of the symptoms of the schizophrenia. So usually some people, most of them have their symptoms. I mean, the schizophrenia emerge in 1 to 2 years or more after these prodromal symptoms. And this could be them having social withdrawal or decline in function, or someone who was performing very well in school will begin to have their academic performance deepen. Some will have this odd or unusual thinking, emotional changes in them, where they could have also mood changes associated with it, then sleep and appetite problems as well. So in schizophrenia, we tend to hear first rank symptoms, and these are symptoms that are of significance in the absence of other things that you could that could explain for it. That could explain it. So first rank symptoms, though significant in schizophrenia, could occur in other things, other disorders. It could occur in depression or it could occur in mania, even sometimes people with substance-induced psychosis. But in the absence of these, then it's most likely schizophrenia. So these are the auditory hallucinations, which are usually third person, where they are running commentary about your activities, describing whatever you are doing to you. And these hallucinations could also be coming from other parts of your body. Imagine hearing voices from your arm or your leg. Would have thought broadcasting, where these people believe that their thoughts are being broadcasted to other people. Other people can read their minds or whatever is going on. Would have thought insertion, where they believe that thoughts are being inserted into their head. Other people around them are inserting thoughts into their head, or withdrawal of thought where they believe their thoughts are being removed. Sometimes they also hear their voices being spoken or their words being spoken while they think about it. That's the thought echo. With thought control, they tend to have these beliefs that their will or their actions, that's the volition, are not by them under their control, but then as a result of some external force controlling them. With the impulse, that's their impulses or urges are being controlled by some external force. The somatic is where they believe that they have certain movements in or on their body are being controlled by some external force, and the affect is where they believe their emotions are controlled by some external force. With delusional perception, this is where they see something and attribute it to a whole different meaning. So imagine maybe you're going home and you see the traffic light turn red, and because it turns red, you believe that you are the president of Ghana. So you saw the traffic light all right, everyone saw it turn red, but then you have attributed a different meaning to it. So this is delusional perception. In when it comes to diagnosing schizophrenia, there are different criteria used. We have the ICD and then the DSM tools that are used. But in Ghana, we generally use the ICD. So the current one is the ICD-11, but which was we started using in 2022. And before that was the ICD-10, but generally the ICD-10 is mostly used. So to fulfill or meet the criteria for schizophrenia, you should have at least one of the following four. So these are mostly the first rank symptoms I talked about. So that's the thought echo, insertion, withdrawal, and broadcasting, or the delusions of control, the auditory hallucinations, which are third person, or a bizarre delusion. So the person should have at least one of the following before you can make a diagnosis of schizophrenia. Sorry. Apart from these four, if the patient has any two of the following, you could also make a diagnosis of schizophrenia. So that's why they have other types of delusions that are persistent. I mean, other types of hallucinations that are persistent and present almost every day. They could have these thought abnormalities in their thoughts of or speech. That's the neologisms, the breaking the train of their thoughts, incoherence or irrelevance of the speech. if they also have catatonic behavior, which I described earlier, or the negative symptoms where they have the anhedonia and the lack of motivation, the social withdrawal and all that. So if two of these are present, you could also make a diagnosis of schizophrenia. So this should have been present for at least 1 month before you can actually make the diagnosis of schizophrenia. For all of them, at least, they should have been present for 1 month. And the person should not be having other disorders that you could attribute or that could explain these symptoms. So if the person is currently using substances and begins to experience these things, you can't say they have schizophrenia because you could use the substance could explain why, yeah, it could cause these symptoms. So you can't say they have schizophrenia, though the two can coexist. If the person is having some brain tumor that is affecting this or some brain pathology that has been identified, then you can't say they're having schizophrenia because that brain tumor can explain what is going on. So with the ICD-10, I mean ICD-11, it's similar to it, just that um, the person should have at least two of these, which are the delusions, persistent delusions, hallucinations, disorganized thinking, or grossly disorganized behavior or negative symptoms. Out of these five, the first three, the person should have at least one of them, and these should be present for at least 1 month before you can make a diagnosis of schizophrenia. So not only should these symptoms be present, there should be impairment in their function. So that's why you need a baseline of the person. Sometimes some people may have certain abnormalities or may seem to be behaving weirdly, but that is their baseline. That is how they've always been. So you can't say they are having a disorder because of how they were. This is how they used to, they've always been. So if there's an impairment in their functioning, be it at school, at home, wherever, then usually that is taken into account. And that's what happens with schizophrenia. There's an impairment in their functioning, especially those who are untreated. So with when it comes to the prognosis of schizophrenia, there are certain things that may make it good or make it bad. With poor prognosis, when the onset is insidious, the person had it at a very younger age, usually before 17, 18. If the person has a family history, has some structural brain abnormalities, the cognitive symptoms and the negative symptoms are very prominent. Usually, we all know they respond better to the positive symptoms. The antipsychotics treat the positive symptoms better. It's the negative symptoms that we struggle to treat. If prior to the illness, the person was already not doing well, that's the premorbid adjustment. The person wasn't doing well, maybe wasn't employed, was just struggling with life, and people who are married, I mean, or married or single, due to the lack of social support, to tend to have poor prognosis. But then it's been shown that people living in low and middle income countries have a good prognosis compared to, I mean, better prognosis compared to people in the high income countries, though there has been some debate about this. In terms of complications, um, we all know what people go through when they have, especially mental illness, the stigma and discrimination attached to these mental illnesses, schizophrenia due to the stigma and discrimination. People, especially who have recovered, can have depression or anxiety after that. There's usually violence to people with schizophrenia. Generally, the notion is that people with schizophrenia are aggressive, but majority of them are not actually aggressive. Mostly those who are aggressive are those who may be having some persecutory delusions or believe that people are having to want to harm them or out to get them. That's when, and most of them do not actually even go out to attack people. But generally, when it comes to violence, it's rather against people with schizophrenia. And some of them tend to use substances in order to alleviate their symptoms. Some have reported that when they take substances, they stop hearing the voices. So it's a coping mechanism for them. Um, there's also a 5% lifetime risk of suicide in people with schizophrenia. Um, these are my references. Thank you.
Thank you so much, Dr. Jude Ayambila, for this interesting session. We'll be moving on to the second presentation pretty soon, but Jude, I would like to draw your attention to the fact that there are some questions in the chat box that you can address. So whilst the second speaker is ongoing, you may want to take some minutes to look through so that when we get to the Q&A session, when we read them out, you could address them for us. Thank you so much. Sorry, you had a comment? Okay. So if you stop sharing, then I can invite Dr. Adusa Poku to take to continue from here. So, Doc, please, I'd like to confirm if you are audible.
Can you hear me?
Yes.
Okay. So can you put my slides on for me, if you don't mind?
Yes, please. Your slide will be on in the next 2 minutes. Sorry, 30 seconds. Doc, can you confirm if your slide is appropriately projected the way you would like to see it?
Yeah, it is. It is.
Thank you
So to save time, I think folks know why we're here. We're looking at our role in managing schizophrenia and the offer of the support that we can offer. Dr. Jude has laid the foundation very, very well. We know the science now, and I'm sure that we'll go back and read again when we give you the presentations. The whole idea is that once you're able to understand this, you find the role that you as a pharmacist must play. And then, because now we're using network of practice, when it moves away from your end, it goes straight either to the clinical psychologist or it goes straight to the psychiatrist. Next slide, please. Yeah, so our objective clearly this evening is to equip pharmacists to provide proactive, compassionate, and evidence-based care to those living with schizophrenia. We are usually in a community pharmacies. Yes, some of you may be in the hospitals, but majority of us may be in the community pharmacies. And we are more or less the first point of call or port of call. We live and we're embedded in the communities. We see people who are having mental challenges, and it's our duty to engage clients, families within our communities and make appropriate referrals. And where we have to do some education, we do. Currently, I'm with a family who has a daughter, 30-year-old. And when they came, they thought it was witchcraft. And it took a hell of time for me to convince them that this is not witchcraft, but it's simply a mental illness. And we have that clear role to play. Next slide. Doc mentioned several things and signs and symptoms. But because we are pharmacists, we are actually interested in medicines. And we are looking at the brain pathway because that is clearly part of the research work that was done to bring medicines that are necessary. So for the mesolimbic pathway, I mean, that's functionally what accounts for the positive signs of schizophrenia, which Doc talked about, the delusions and hallucinations, etc. Now, it is saying that if you block the dopamine type 2 in the brain, you realize that you actually suppress the symptoms. So that area where you need agents, drugs that can actually block D2 became a window to manufacture certain medicines. But at the same time, as we try to block the D2, it also affects the cortical pathway, and that also may worsen the negative symptoms that Doc talked about, the poverty of speech and all the withdrawal, social withdrawal areas. It may worsen it. Then when you look at the nigrostriatal pathway, which actually controls our motor function. If anybody has seen anybody who has extrapyramidal symptoms, you realize that it can be really scary. And clients who experience and caregivers who experience these things actually get scared. And therefore, as pharmacists, we are closely in link, for instance, with the FDA to make sure the adverse effects and side effects of drugs are reported by their pathway and systems. We must be aware of these EPS issues, the tremors, the tongue pulling out, and all those things. I think we must be aware. Now, if you look at the tubular area, which actually controls prolactin, once the D2 is also blocked, then you realize that, of course, hyperprolactinemia goes on. People will get gynecomastia, some of them will get glyturia, and I'm almost surprised. You hear people come to the pharmacy or the hospital pharmacy and say their sexual function is not to the best of their ability. Sometimes because of this particular condition, some of them will even stop taking their drugs. And as pharmacists, we know how to counsel them and to encourage them to take their medication, of course, and also to link up with their practitioners that this is a side effect that the patient is suffering from. How do we go about it, Doc? Next slide. So, as pharmacists, we have generally about 3 groups of medicines. The first generation medicines, I'm sure many of us, even before school, we all heard of Lagatel. And I remember at Confonochi, we just used to joke, oh, yeah, Lagano. It means the person has been given Lagatel, and sometimes you clearly feel that they are very sedated, very drowsy. You don't know whether the person is recovering or not. But apart from chlorpromazine, we also have haloperidol, one of the very common drugs we use in this country. Patients who can afford the injection actually go on it every 4 weeks. But this is a drug that it takes about almost 3 to 4 weeks for it to optimize, sometimes even up to 6 weeks. So before a psychiatrist or a prescriber will put a patient on, that patient would naturally be on maybe haloperidol 5 milligrams for a while to stabilize on it before they now switch onto the decanoate. But these drugs, as mentioned before, have high risk of EPS, and as pharmacists, we must be mindful. Flufenazine decanoate is same third generation long-acting antipsychotic. We call it Modicate on our market, usually between 2 to 3 weeks before it pulls its effect up. And for people who have chronic non-adherent patients, very difficult for them to stick to their medication. Flufenazine decanoate or Modicate is good for them. But mind you, this drug in particular is associated with not only EPS, but also tardive dyskinesia. And we know how sometimes irreversible this particular condition can be. And pharmacists, we must be watchful of these things. Next slide. Now, not only the first generation, second generations too are there. The difference really is that the second generations have a better profile, side effect wise. They are better. So we all sell Risperdal tablets in our pharmacies, many of us. And there's an injection form which is given every 2 weeks. It requires a cold chain at the beginning, but that's transportation, once you mix it, you don't need a cold chain again. It's just room temperature and the person uses. So that's risperidone constant. But now it's even been developed further to be given once monthly, paliperidone. I'm sure many of you have seen these medicines at NS Chemist and other places. Even in the States now, they have a 3-month injectable. And can you imagine that if it were not for the cost, you're just giving like 3-4 injections in a year and you are free to go. And as pharmacists, one thing I've experienced over the years when I used to work in this particular area is that we don't give opportunity for patients to decide. There's some patients and their carers who can afford to put their patients on or their family members on these medicines. And so for me, let's talk to our psychiatrists, let's talk to our doctors in our environment, because now we are decentralizing mental health across the country. So it's very difficult to treat cases that now are being projected and referred to the psychiatrists because there are not many, less than 100 in the country. So for the doctor in your hospital who may treat a client, when you're a pharmacist, some of these exposures can be discussed with them. The person can talk to the psychiatrist by phone, and then they can know what to do. Next slide. Not only risperidone, but then we also have aripiprazole, the maintainer, which is for a month, and then we have olanzapine palm weight. There's a problem sometimes, usually with olanzapine palm weight, because sometimes if you're injecting and you go and hit a vein, then there's a rapid release of olanzapine, and then the person gets delirious, sedation, and all those things, which we call PDSS. So it's not used often in Ghana here. Next slide. So what are the key considerations why we're using long-acting antipsychotics? I mean, for people who have improved adherence, for patients with frequent relapses because of poor medication compliance, is good. You go for one injection for a month or 2 or 3, you are good to go. Apart from the constant, really, and the abilify maintenance, basically all of them now, they are not coaching. They've been formulated in such a way that they not need to be coaching in that. Next slide. But as I said before, you must stabilize them on the tablets, be sure that they are positively responding to it, because if they are not, and you put them on long-acting, it means that you've locked the side effects in for such a long time, and that will not be good for the patient. So always, let's remember, put them on the oral. If they can tolerate it well, then they will go for the injectable. As I've already mentioned this, that it takes about 3 weeks to 4 weeks to get a patient stabilized on the haloperidol injection. So the tablets go first, and then we are good to go. Next slide, please. Yeah, so as pharmacists, let's have this discussion with all prescribers that it takes about 7 to 14 days after you've injected before the drug starts coming into the bloodstream. So it is good that the patient continues on the oral tablets throughout. And then the injectable is such that, for instance, if somebody is on haloperidol 5 milligram, then we say the initial dose will be between 10 to 20 times. So if it's 5 milligram, 5 times 10, that means 50 milligram. If it's 5 times 20, that's 100 milligram. It means that the person will have to be on anywhere between Hadol 50 milligram and 100. And of course, you can maintain them usually afterwards between, let's say, 25 to 50, depending on the severity of the condition. Next slide. Yeah, so I want pharmacists to pay attention to this EPS area. Doc talked about it. But then again, the dystonia, the Parkinsonism, the akathisia, and the tardive dyskinesia I mentioned, these are signs that pharmacists must know, so that when we engage with our clients who buy medicines from us, we can educate them. If they see those things happening, they can report to us, and then we link them directly to their clinicians or the psychiatrists, or they themselves, the caregivers, can call the psychiatrist and say, we've seen this in our relatives, or I've seen this in myself. Can I come over for a discussion? And then we save them in time. Next slide. Yes, so how can we avoid some of these EPS issues? One, we go slow in all antipsychotics as much as possible. Start slow, go slow until it becomes optimal. Whenever you do rapid dose escalation, you can get EPS occurring. And that is something that we must take care of. And especially to when the person is dehydrated, sometimes EPS can be provoked. And the doses, as I said, must be gentle, and then you increase maybe every 2 weeks, gradual increase until optimal therapy is achieved. Next slide. Yeah, so why is it that the second generation drugs, the piprazole, the olanzapine, and the risperidone, etc., they seem to have less EPS effects than the first generation antipsychotics. And as we said before, the first generation largely depends on antagonizing the D2 receptor. But the second generation, they make sure that they also have effect on the serotonin 5-HT2A receptors. Okay, so it means that the amount of blockade in the gustatory pathway, which controls our motor function, is less. So you don't have a lot of those motor dysfunction occurring. And then we also find that because of this 5-HT, serotonin 5-HT receptors, when it comes to, let's say, the mesocortical region, they're able to push dopamine up the prefrontal cortex. And Doc talked about the executive function that the prefrontal cortex has. So once we push a bit of dopamine in there, then the natural negative effects that they have, dopamine, as you know, will cause a little bit of excitation. Then the social withdrawal and the anhedonia and all those that they experience is minimized. So it is good that we use second generation wherever we can afford to use them. Lastly, the quetiapine and clozapine are some of the second generation medicines that have minimal EPS risk. Risperidone, paliperidone, moderate in that sense, but largely there's always that risk. It's not 100% EPS proof. Some of them occasionally are breakthroughs. Next slide. So if you're a pharmacist and in your hospital, EPS, occurs in a patient, we must know how it's managed alongside with the clinicians. So for its motor issues, then we have to use IMO IV anticholinergic, and then benztropine is one such agent that we use. If you've got Parkinsonism occurring, then try hexafenidal, which we call Attain. In Ghana, is also used. In fact, that's even the purer form of anticholinergic effect. But mind you, benztropine has IV and IM. So when you want rapid results, it's good. As for Attain, it's only tablets, so we are limited in that regard. For people with akathisia, propranolol, because of its centrally acted effect, is able to make sure that these things are resolved. Of course, you can also use benzodiazepine like clonazepam for it. Now there's a drug here, VMA2 inhibitors, barbedazine, but we don't have it in Ghana. I don't know whether anybody has come across it. So for now, if you have a TD, it means that we encourage our clinicians now to switch to clozapine because we don't have VMA2 inhibitors readily on the market, and nobody wants to keep a patient suffering from tardive dyskinesia before we get irreversible condition occurring. Next slide, please. Again, the neuromagnetic syndrome is very rare, but please let's take note because it occurs and is deadly. So when you have fever, muscle rigidity, altered mental status, autonomic instability, this is a red flag. And if so happen to a patient, rapid management will have to set in to save the patient from NMS. Next slide. It's rare, but at least we need to know how these things happen. Next slide, because of time. But maybe let's go back. Let me just bring one point down. A doc talked about sometimes comorbidities. So when you look at the last slide, for instance, apart from the risk of rapid dose escalation, dehydration, parenteral administration of these medications, sometimes somebody could be using lithium. Maybe the person could have bipolar, mania, management, etc. Let's be careful that in using these potent antipsychotics, and somebody is on lithium, as pharmacists, we must be conscious of this and make sure that we advise accordingly the patient. If you see anything in this regard, please report as quickly as possible because the potential is always there. Next slide, please. Good. As soon as that happens, means that we have to stop all the antipsychotics. We discontinue overdrug is there. The doctors will go for the IV fluids, monitor everything. We all know bromocriptine, pallidol, as a dopamine agonist. So once the D2 blockade is done severe and it's causing this problem, we go for bromocriptine or amantadine, and then we try to reverse the situation. And of course, if it's severe, ICU comes into the picture. Next slide, please. Our role is to educate. Education is important. That's why we must be on the alert. We must be talking to our clients. We must be alerting them, or caregivers of these things. Sometimes in Ghana, we don't look a lot at adverse effects of medicines. And sometimes we may feel that, look, the side effects of these medicines and the disease itself, how do we even differentiate it? But now that we are learning, I believe that we can be very mindful, we can be aware of our role, and accordingly raise any alarm when necessary. Next slide. Next slide. We will give these ones to you to be able to read. I think I've already said it, that the fact that the serotonin 5-HT2 is able to help bring them out of the negative symptoms far better than the first generation medications because of the neurotransmitters that are involved. Doc talked about it earlier, the glutamate, acetylcholine, noradrenergic systems. All these things help to make sure that the second generation antipsychotics are able to help patients do well when negative symptoms are present. Next slide, please. Yeah, next slide. Because of time, we want to wrap things up. So there are some agents like cariprazine. It's not very common in Ghana, but for primary purposes, that one and amisulpride, these are the ones that have been shown actually to affect the primary negative symptoms. But the second generation overall, because of the ability to reduce depression, on the average, they offer moderate effect and better effect than sticking down to the first generation medication as far as negative symptoms are concerned. So even the second generations are not, they don't have strong effect on the primary negative symptoms. As for secondary negative symptoms, they're able to manage it better. And so far, the strongest one that we have seen as far as primary is concerned is a cariprazine. Next slide, please. Good. The next slide. This one's pharmacists, when we get it, we should be able to read it because we want to save some time. We want to, at least I want to end my presentation by 9 o'clock. Next slide, please. Yeah, so our role here, let's monitor for the adherence. Because already, for many of us who are even taking our normal antidiabetic drugs, metformin, amlodipine, etc., how many of us are able to take our medications? Then imagine a client who has a condition where sometimes he loses insight, even of what is disturbing him or her. And therefore, our role is to help with adherence and then also to monitor the side effects in there. And then we inform the doctors. So pharmacists in the hospital pharmacists, please, let's pay attention in this regard and let's not confuse the symptoms of a disease with the side effects of the medications. If we are able to know side effects very, very well, we'll be able to detect them and inform our psychiatrists. And then, of course, when you are going, you have to offer the alternatives for them to be able to use. We must also give education to the patients and to the carers. I remember just about 3 weeks ago, our paper was written for a client. I think the girl was like 16. And he came with the mother to my pharmacy. And even though aripiprazole is not supposed to really to have a lot of motor side effects, for her, it was still kind of breakthrough and things. And when we pulled the drug out, the girl said, I don't know. And the mother was angry. She said, why would you take? Why don't you take it? And I said, no, no, ma. I have patience for her. So I told her, why would you take it? She said, no, doctor, me find me say, I said, have you seen the last drug there? Then she nodded. I said, it's called attain. The doctor has added attain to it so that one son and So you see, the doctor is thinking about you. He's considered your problem. He's giving you a drug that your motor function. So I waited for her buy-in. Said it will be fine. I said, okay, and now befa. Then we dispensed. I said. Then I also took the opportunity to advise the mother. Then look, have time. Don't think that he's just off. She's not off. She's experiencing the effects of the drug. You are not experiencing. Maybe if you experience it, you too will not take it. So have patience for her, and everything will be fine. And the two left peacefully. This is the role of a pharmacist at the counter. Next slide. Good. I'm just ending the whole presentation. This very slide, later on, have a look at it. You find out why the second generation will have metabolic syndrome. Sometimes people will be on these medications and they realize that they have impaired glucose buildup, and some of them will develop diabetes. Some of them will have weight gain. The explanation is in there. So for the weight gain area, clozapine and olanzapine are high risk. The moderate risk is risperidone, quetiapine, and paliperidone. The low risk are aripiprazole and zidone, which is also in Ghana. The last two, I don't find them on the market. So as pharmacists too, when people are on this second generation drugs, they are good for both the positive and the negative symptoms. But we must also be mindful about the cardiovascular risk, about the development of diabetes, and about poor adherence. So once a while, when we are dispensing, if you have access to the folder, if you're using the LIMS and we have access to the information of the patient, please let's scan through. When was the last time the glucose measurements were done? HbA1c were done, the lipids were done, maybe some dyslipidemia is even involved. These are areas that you can talk with the team and then you all think through it. Because sometimes even for hypertensive and diabetics, certain common tests that you think should be done are not even done for them. Okay, so how much more this one is not directly an NCD, but then it can be missed. So let's think about that as well. Lifetime interventions, it's our role to educate the patient and then to educate the caregivers. Let's alert prescribers if switching is warranted. Let's have a discussion with them. You don't go telling them, doc, you must switch, you must do this. Please, let's learn how to communicate professionally. Let's bring the suggestions. Let's bring the evidence-based approach. Every doctor will want that, and every doctor wants the client to do well. So once you're a pharmacist and you engage a psychiatrist and said, doc, this is what I've seen. I think it's about time we consider this. What do you think about it? And that will be good. Like if you see an HbA1c going up and still the patient has to be on it, then you will consider metformin for the patient in that sense. So at least we're able to manage the patients in this regard. Next slide, final slide. So I will leave these ones. Let's go to the very end. I brought some cases in there. And again, these are the red flags that I said we must be looking at because now all these things. So all these things, please read through them because of time. As I said, I want to end at 9. This one is good. The referral pathway and partnerships. We must know our district psychiatric nurses from the Mental Health Authority and the Ghana Health Services. We must also have telephone numbers of psychiatric clinics around our pharmacies. We must know the MH community outreach teams. We must keep directories. We must keep phone numbers. Look, if somebody came to your pharmacy now and was very agitated, what will you do? Is there any hotlines from MHG that we pharmacists must do? There is, but probably we don't know. Are there some organizations like RIMA, who look after, provide shelter? As pharmacists, we must know all these things so that we can do appropriate referral for NGOs that may help people who may be destitute and may not be able to do these things. Next slide. Yes, next slide. Good. So all these things are tools that we can use to help our clients. Next slide. Next slide. Yeah, this is what I was talking about. We need to have emergency contacts on speed dial, and then we offer the necessary help to such people. God, these things can occur to anybody. Next slide, please. Here we must educate our staff so that if a mentally challenged person comes to our pharmacy, our staff will not play the jokes, they will not laugh, they will know it's serious business. Just like the way we put up our diabetes posters, let's also put mental health posters and make the place friendly. Yes, I realize that Enyo has put the MH toll free line. Please, let's copy it. Let's copy it because you may need somebody may need that number, and you may need to call that number for help for somebody. So let's copy that number. Next slide, please. Yeah, so the parent of the family, caregivers, and in fact, pharmacists, please, let's educate the family members because most time they think it's witchcraft. They don't understand. In fact, I have to use my own as an example that I'm hypertensive. I take drug every day, and I show it to the drugs to the clients. Don't say let's not tell them that they are managing it. So I say, I'm a pharmacist. I'm taking my medication every day. So should you also take your medication every day? And sometimes when I do that and I tell them, they understand. Next slide. So, pharmacists and mental health. Let's bring the red flags. Let's keep them at the counter. Let's have some WhatsApp discussions with our psychiatrists, with our clinical psychologists. Let's have a common page, a digital platform that we can all talk there. Let's develop some mental health first aid in our training programs. I think it's something that we'll do. And even if we can put some stickers in our pharmacies, maybe we will lead that charge. Where we say that this pharmacy is a mental health friendly pharmacy. We put a sticker there, which is welcoming to everybody. The very last slide. Yes. And not only this, most of our people go to churches, whether we like it or not. And we have to link up with them. We are spiritual, or somebody said we are spiritist, and we have to position ourselves as community mental health educators in that sense. Please, let's take action. Let's take action. We've heard all that we need to hear, and let's take action and make sure that we do the things that we got to do. Luckily for us, National Health Insurance is now treating schizophrenia. We fought for years of advocacy, but finally, that is some good news in there. We need the mental health authority to recognize as they have. We need the Ministry of Health to recognize community pharmacists and integrate us. But I know that there are some training in the pipeline from the Ghana Health Services and the Mental Health Authority in this regard, where pharmacists are going to be trained on basic things like screening for anxiety, etc., etc. So the conversation is good, the partnership is good. It can only be better. Thank you very much. Yeah, so those are my final words. I think my 9 o'clock is good. We are only dispensers of medicines. We are gatekeepers of hope. That is the last one I will tell all of us, encourage all of us. Let's start acting now. Thank you.
Thank you so much, Dr. Adusa. I think we can now move straight to the question and answers section. I'd like to confirm if Dr. Jude is still with us.
Yes, I'm still with you. Yeah.
Fantastic. So we would start our Q&A right away. Um, I would be reading the questions out and I would ask my dear speakers to address them. After that, we'd also open it up for colleagues who would also want to ask a question directly. The first question is that what are the current genes identified to be associated with the disease? Does RNA therapy hold promise for treatment?
So, several genes have been identified when it comes to schizophrenia. Um, if you're talking about what has been identified today or last week, I can't really tell whether there's any one that has just been identified recently, but we have several of them. The one that has been shown to be mostly associated with schizophrenia is the disbinding, which is on chromosome 6. We also have other ones like the DIX1, the DRD2, uh, the NRG1 comes. There are several genes that keep on coming up regarding schizophrenia. And regarding the RNA bit, it's still experimental. You know, RNA we know is responsible for protein synthesis and also for gene expression. So because there's some genetic component to schizophrenia, they are trying to see how they can manipulate this with the RNA. But you know, it's quite difficult getting things into the brain. So it's still an experimental thing. Yeah.
Thank you. Um, I'll go to the second question. The first question is a two-in-one question, so I'll go with the first one. Is there any reason why most cases of auditory hallucinations are negative?
Um, so they are not mostly negative. I've not come across anywhere where they say they are mostly negative. Yeah, the negative ones are common, and they are the ones that are usually distressing. They cause a lot of distress. If you hear a voice that is always hyping you or telling you good stuff, you'll not really be so much concerned about it, isn't it? Because everyone usually wants someone to say good things about them, but the ones that are distressing to them is the regretted ones. Imagine someone just on you all the time telling you stuff that you don't like to hear or insulting you. So I think it's not that they are mostly the regulatory. They come in different forms, like not just the regulatory voices. Yeah.
Yeah, thank you. The second part is that with regards to the delusion, it was defined in terms of cultural belief. In the Ghanaian culture where there are many religious people and the belief in special abilities such as the ability to heal is common. When can a person's claim to have these special abilities be considered delusional? I
Mm.
think it's very practical.
Yes, it is. So it can be quite tricky as well. Like you mentioned, in the the Ghanaian society is a religious one, isn't it? And people tend to be quite spiritually inclined. So there are several things you take into consideration. First of all, when it comes to delusions, they mostly have a personal significance to the individual. So if I'm psychotic, my delusions will be different from Mark, if Mark is psychotic, because we all do have different beliefs and perceptions. So psychosis, we have fantasies and all that. Like when you delve or dive into someone's brain, like there's so much going on, but you're able to tell what is real from what isn't real. And we all do have one form of fantasy or another. And sometimes we think about certain things, but we know this isn't true. But once psychotic comes in, the line is blurred. You're not able to tell that this is real and this isn't real. And so, what you are experiencing in life or what you previously experienced in life could begin to manifest as a delusion. That being said, you also have to take into consideration the person's premorbid condition. So before the person began to behave this way, how was that individual? Has there been any sudden change? So if this was a very quiet person and then now it's all over the place, this is a sudden change, isn't it? Though sometimes it can be insidious. Is the change affecting their functioning? So these are the kind of stuff you take into consideration. Mostly it affects their functioning. So be it their social life, their work life, family life, or something else. It also affects how they function. So if today I wake up and then I say, okay, let's use Mark for example. Mark, I'll continue to use you. So since uh, uh, Mark is quite spiritual, isn't he? But then you don't find Mark walking on the street and then he just meets some random person and then tells the person that you are sick, I'm going to pray for you. Then, regardless of what happened, he insists on praying for the person, may even have to bundle the person up to pray for the person. So, and then he'll believe that he has actually healed the person. Meanwhile, the person, nothing has happened to the person. You see a cripple, you claim you are praying to heal the person. You pray, nothing happens, and you claim you've healed the person. You just meet anyone on the street and you claim you've healed the person. So usually the evidence is also there. It can be quite difficult if just talking to the person and you don't really know the person. You have no background information about the person. But if you have this background information regarding their premorbid state, how they've always been, their personality, and their functioning, together with other evidence present, you'll be able to tell whether this is a delusion or not. Though sometimes it can be quite tricky under certain circumstances. Yes, definitely there are some people with the healing abilities, but when you take those other factors into consideration, you'll be able to tell that this person is delusional.
Thank you. And our last but one question, I think, it goes this way. DSM has mainly been the tool for diagnosis. Do AI-based application into bracket biomolecular level or phenotypic level bracket close for early diagnosis compared to current diagnostic tools perform better?
These AI models are also still experimental. Um, yes, the thing is, if these things are able to come into fruition, they will be able to diagnose better, especially in the early stages, especially the prodromal, in that because we have genetic component to the schizophrenia, these biomarkers will be able to pick up this stuff quite early than um, using these diagnostic tools where you have to wait till the symptoms surface before you'll be able to make these diagnoses. But these AI biomolecular markers are still all experimental, but should they be able to work it out, should it be able to come into fruition, then they'll be better at diagnosing schizophrenia than these diagnostic tools that we use.
Thank you. And our last question is actually two in one. What is a typical duration of treatment for schizophrenia? And the second part is also criteria for stopping treatment, if that's possible in the management of schizophrenia.
Okay. So there's no duration for treating or specific duration for stopping the treatment. Schizophrenia is a chronic illness. So it means that you're having it for life, just like hypertension and diabetes. Though we previously they had this 1/4 rule, but now people are trying to do away with it. They had this 1/4 rule in schizophrenia where um, 1/4 or 25% of people, those who have been treated, have complete resolution of the symptoms. Another 1/4 will have most of the symptoms resolved, but then they'll still have some persistent symptoms. Um, Another 1/4 or 25% will have just some symptoms resolved and then a lot persistent. And then the last 1/4 will have no resolution of the symptoms at all. Whatever you throw them with, it doesn't work for them. So that's the bit about it. So some people, upon treatment, have complete, just a few of them have complete resolution of the symptoms, and then they never have it again. So it's a chronic illness. There are some that have it in an episodic manner. So it could resolve, then remit, they go into remission, and then it remits again. I mean, it relapses again. So you have to treat the person for life. But then there are certain circumstances. So that's where patient-centered care is important. You have to have this chat with the patient, let them know that it's chronic. But then the thing is that if you don't treat it, though, it will just progressively get worse, especially with the cognitive decline. But on treatment, you can get better and you go into remission. There are some patients who prefer to go off the medications when they are in remission for a long time or after several years. Some people will prefer to go off the medications. But generally, most people are on it for life, so there's no duration for treatment of it.
Thank you, Jude. And our last question, and we'll bring the session to a close. And with this, I would also invite Dr. Dusa to also comment on. It's a scenario. A close friend of mine has been suffering from schizophrenia since completing tech in 2001. How can a structured bi-directional communication model between Ghana's community pharmacists and psychiatrists be optimized to ensure real-time pharmacovigilance, medication adherence, and early identification of metabolic and extrapyramidal side effects in patients with schizophrenia while respecting patient autonomy and navigating the limitations of data sharing in outpatient settings? This is more like a problem statement for a thesis work. Comments from our speakers. Should I repeat or is it clear?
Yeah, for me it's clear. But let Dr. Jude have a go.
Okay.
Okay, all right. So in managing a patient, we tend to um, especially go in line with the paternalistic approach where we want to dictate to the patient whatever we want them to do and all that. But ideally, management should be what multidisciplinary, where you have the various cadres involved, the doctors, the pharmacists, the nurses, the community health nurses, and all that coming in, psychologists, everyone coming on board to come out with a plan, a care plan for the patient. So ideally, there should be a multidisciplinary meeting for these patients, but then we don't have that luxury, do we? So everyone has to play their role. Um, the doctors have to prescribe the medications. Um, you, the pharmacists, usually dispense. And I think you also monitor the side effects, don't you, as well, for the patients. So generally, when patients come for review, is the responsibility of the doctor to actually also try to um, find out whether they have any side effects from these medications. And I think if that isn't done, that's why it's teamwork from the end of the pharmacist or even the nurses. Sometimes these are identified, and if these are identified, then the necessary route of communications have to be taken to ensure that the patients receive the appropriate intervention. We've come across several patients who are experiencing side effects from certain medications, but then they keep on being prescribed those medications. So if one point of contact has missed this, then the other should try to make up for this by identifying. So we always have to bear in mind that these drugs come with side effects. So we have to always monitor patients for that.
Yeah, if I may continue from where Dr. Jude left. In fact, ideally, what this questioner may be asking us, I think that if we're able to have electronic systems where we will talk to each other, of course, certain data of the patient may be reserved, depending upon what levels a person can have. Because if I was holding my phone and I could go to a site and I know that the Dr. Juice patient that he's treating, he picks up his medication from here, I realize that his adherence is an issue. I can easily talk to Dr. Jude about it. Do we have to let the patient see a psychologist because of problem that they have? Now, what we do is more or less informal. I've got loose associations with some psychiatrists over here. And one of the interesting things of many of my schizophrenic patients is that whenever they can't sleep for the next 2-3 days, you can be sure that relapse is beginning. They'll start losing insight. And then I talk to one psychiatrist, okay, what do we do? And sometimes, okay, look, let's put the person on just melatonin for 1 week and let's see what goes. If a patient is suffering from some form of side effects, I discuss. In fact, there are several doctors here that I discuss. Current cases that I'm even working on with some doctors. We have what is so informal. It's like you call the person and in fact, the current one I'm doing, it was such that the mother used to call me every 7 o'clock p.m. for the last 2 weeks, trying to make sure that her fears are managed and that the drug will start kicking in and will start working. And the psychiatrist was actually even out of town in Europe, and we're doing WhatsApp calls and seeing the way forward. And this is a patient who now, because the MRI scans and everything done, it's more like comorbidity of, psychogenic epileptic seizure in addition to the schizophrenia. So on aripiprazole, and then some Keppra probably may come in now. So it's all informal, but I think that we need to start from the informal basis until finally we can go electronic, protecting the patient's data, but at the same time rapidly communicating amongst us, because network of practice now is everywhere. Network of practice is everywhere, and without that, then the client will not have the best of the professional help that the person may need. This is what I can say.
Just a follow-up. Do you usually have access to the patient's electronic data?
Yeah, in Ghana, that's the problem we have. We in the community, we don't. Like, for instance, my roommate in the UK has access to certain informations, and therefore, even when he does intervention, he puts it on. So the GP knows what he's done. But here, we don't have any access. Maybe the pharmacists in the psychiatric hospitals may have access. Maybe they are online. Can they tell us, Enyo and Raina, do you have access to the LIMS? And can you make interventions and call the doctors in real time?
Oh, yes, we do. You have access to patient information and you can actually make interventions. there's actually a portion on limbs that for pharmacy interventions. And for that side, usually doesn't appear on the clinical note. So what we do is that for ward pharmacists, we document our interventions on the clinical page, and then it's also forms part of the clerking notes. So you see what the pharmacist has done, the intervention and all that, the advice, everything we give is also documented. So that's the system now.
Yeah, so that means the hospital is fine, but then when you come to the community, there's zero connection, no communication.
Okay. The community has a long way to go.
Yeah.
Are there any plans for the LIMS or any electronic?
Just a comment. Does the private sector hospitals to have access to the LIMS, or is exclusive to Ghana Health Service and public sector facilities?
Currently, I think it's for the rollout is for public sector, but then the LIMS has, if we follow the plan of rollout, I think eventually it will be the network of practice will be the way to go. So the first reach out to community pharmacies is through the e-pharmacy network, which is actually a function on LIMS, where prescriptions that clients do not get in the hospitals are pushed into the pharmacy. So I think we can push for we can also push for a function that will allow the community pharmacist access to be able to get the patient information. I think if we are able to work out data protection and everything in relation to confidentiality and patient information not being everywhere, and we have a good legal system where it would be binding on us that if you falter, you'll be sanctioned for leaking a patient's information. I think it's the way to go. We can push it to Pharmacy Council and to the e-pharmacy network because it's linked directly to the LIMS currently.
Well, thank you, Famrina. Last comment from our speakers. Dr. Jude, you may take the last comment, and then Dr. Dusa.
So it's been an interesting session, and this is thank you once again for this opportunity. Yes, I know there was very short time, and especially at the end we had to rush, but we have to understand that, and the take home is that mental illness is common. It's everywhere. It could affect any one of us. Schizophrenia is a type of psychotic illness. Generally, there's a criteria the person has to meet before this diagnosis can be made. Early detection is key, especially in the process of recovery, as it helps prevent the cognitive decline, which occurs in people who are not on treatment for schizophrenia, because it's been noticed from imaging of the brain that there's a reduction in volume of the gray matter of the brain. So this is why these people tend to have cognitive decline, and then especially in the temporal area, that's why the auditory hallucinations are also very common. So early identification of these patients, you don't necessarily have to make the diagnosis. All you need to do is to identify that this patient is psychotic, and then the next step is to refer to the appropriate place where the assessment can also be done, and then the appropriate intervention put in place for them. And also, let's remember that it's also about teamwork. I know doctors can sometimes be sort of pompous and bossy and all that, but it's about teamwork, and we have to make sure or ensure that, especially if the prescriptions are not done right, or if there are um, side effects that the patient is experiencing, we have to ensure that we draw the attention of these doctors, or maybe the appropriate interventions are done, because people tend to be non-adherent to these medications because of these side effects, like Doc mentioned. So let's ensure that we try to monitor their side effects as well. If they come to you to take the medications, we just ask one or two side effects to see how the patient is doing. And yeah, let me not take much of your time again.
Yeah. My concluding remarks will be that many pharmacists practice in community pharmacies. We sell these medicines, or we dispense these medicines to people who come with prescriptions, just like we do for hypertensives and diabetics, etc. And now that we're empowered and with the knowledge to know first generation medicines, second generation side effects, efficacy, etc., we must now not just dispense and not say anything to them. We must let them have a feel that we are interested in them. So these medications, how long have you been taking it? Has the response been good? When you talk to clients and you talk to family and caregivers while you are dispensing the medication, they realize that you are not just dishing the medicines. They realize that you have empathy, you are interested in them. In that sense, if there's any untoward effect, they have the confidence to come back to you. And I think that if we're able to reach out to our clients in this manner, they will significantly improve the way we treat them. Their mental health will improve because they realize that we care for them. After all, as pharmacists, our motto is amicus humani generis, friends of the human race. Let's show friendship also to mental health patients. Thank you.
Thank you so much. On this note, we bring our session to a close. But before we do, we'd have to invite our CPD chairman to make our last remark. I also want to mention that we'll take the permission of our speakers, and then once we have them, we would share and circulate the slides to our members. The recording would also be made available, eventually uploaded onto the YouTube channel of the Pharmacists in Mental Health Ghana YouTube channel, and so that would also be available in due course. Thank you so much. Famrina, your last comment so that we pull the webinar to a close. Famrina, you can unmute now. Yeah, if it is working.
Yes, it's working now. So thank you so much. I must commend everybody who is here. We are happy that we're able to bring some insight to about 140 plus pharmacists. And it was exciting to see that we have this number of pharmacists ready to learn something without being fixated on CPD points. We thank you. We are grateful to Dr. Ayembila and to Dr. Dusa Poku for this insightful night. We trust that we would take these things and practicalize it. Let's not just learn it and leave it here. And thank you so much, everybody, for staying on. And we hope to see you very soon with another exciting episode on mental health. We want to make mental health exciting and attractive to pharmacists as well, that we don't shy away from it. So let's be friends of the mental health patients as well as our president stated. Thank you so much for staying, and have a good night.